Okay, well, now we're going to start the lecture you've all been waiting for. What if you predict it's going to be a difficult intubation? How are we going to manage that? And I love showing this, and especially love showing this when Carl is here. He's one of our anesthesia partners. This is the anesthesia algorithm for difficult airway management, and I'll highlight it in a little bit, but if you look closely there, it says cancel case, regroup, and that's not an option for us. So what we're going to talk about is this sedated intubation, something that we've already established that with the exception of I think one or two of us, we've never been taught before, certainly not formally in residency. And this is the concept of, wow, I predict they're going to be difficult, so I'm not going to intubate them. But wait a minute, didn't I just tell you that the best intubating conditions are in a paralyzed patient? So why would we not paralyze somebody that we predict is going to be difficult? Anybody?
They can't breathe on their own.
Yeah, and it may be impossible to get from A to B. This patient may be so difficult that they cannot be intubated orally, and you can't get from A to B. Now I've paralyzed them, and I've got no option of a definitive airway other than a surgical airway. So we want to try to avoid being in that situation. So, you know, this would be a poster child patient for a sedated intubation. Obviously, from across the ED, you're going to predict they're going to be difficult to intubate. So LEMON is the acronym that we talked about for predicting a difficult airway. And if you hear a lemon, that means if you've got to hit a red flag on your lemon, that means there's a waterfall. And what we used to do is we say, well, this is probably going to be tough. Oh, well, let's paralyze and here we go. And we just went for it. And most of the time we were successful. But sedated intubation gives you a chance to scout the rapids to see if you can safely get past the potential issue. And it's a comparison between a strategy of hope versus a strategy of caution. And we have the equipment and the technology and the skill now to do sedated intubation, and that's what we should be doing for patients that are predicted to be difficult. So there's two requirements when you do a sedated intubation. One is topical anesthesia, the other is sedation, okay? So topical anesthesia, so maybe we're going to go fiber optic because it's angioedema or Ludwig's. If we're going to use a video laryngoscope or direct laryngoscope, we're going to use basically the posterior oropharynx is going to be our target. The next part is procedural sedation, which we're already comfortable with. So here's the thing with sedated intubation. If you're going to do any topical anesthesia, it's going to take some time. Now you can't just give ketamine with no topical and do it that way if you have to do it quickly. But usually if they're deteriorating quickly, you're going to paralyze them and just go for it, and if not, crike them, and either way you're going to end up with an airway. But if you have time, these are the retropharyngeal abscesses that are slowly getting worse. They're the allergic reaction. They're the neck trauma with a slowly expanding hematoma. Potentially, I mean, these are the different kind of scenarios where you predict it's going to be tough, but you have some time. The more topical anesthesia you use, the less sedation that's necessary. And anesthesia, particularly pulmonologists, when they do bronchoscopies, can you imagine being awake and having a garden hose run in and out of your trachea? And, I mean, that's how good they are, that basically these patients are awake with, if anything, homeopathic sedation, but it's all topical anesthesia, so they're able to tolerate it. So glycopyrrolate is a handy trick to have up your sleeve. What does glycopyrrolate does? It basically dries out all the mucous membranes. The advantage of drying out the mucous membranes is that all your topical agents work much better. Now, Carl says that it only takes about 5 or 10 minutes after he gives it where he thinks he's got a therapeutic effect. I've seen more like in the 20-minute range, which seems to be a little bit long for what we're doing. But when you think about it, by the time you get all your bells and whistles together for somebody who predicts to be difficult, it's probably going to be 20 minutes anyway. So glycopyrrolate is one trick to have. It's going to make your topical work better. So if you're going through the nose, you want a vasoconstrictor, Afrin or phenylephrine. That's because you want to shrink the blood vessels to decrease bleeding. That's going to complicate things. And there's nebulized lidocaine, tetracaine. I like to use lidocaine on a face mask neb, and I use the pink box of lidocaine, which is in your crash carts. It's 100 milligrams, and it's the perfect volume for the neb chamber. And then I just hook them up to that, and it takes about 5 minutes or so. I actually use that for all my NG tubes as well if they're not emergent. It makes it much more easy to place and comfortable for the patient. Other techniques are you can take lidocaine in a syringe with a 18-gauge angiocath and just squirt it on the posterior oropharynx, squirt it on the back of the tongue, and do that kind of in series, every minute or so for a few minutes. They talk about putting benzocaine ointment on the back of the tongue, and it warms up and drips down and does topical anesthesia on the posterior oropharynx. Benzocaine spray, which is hard to find anymore. Gargling lidocaine, it's hard to find the patient that'll be cooperative enough to gargle lidocaine. But those are the different options. So in terms of time, to get good anesthesia and to, basically to pay a lot of attention to the patient, it's going to take about 15 minutes. It's going to work better if you get dry mucous membranes, either with atropine or with the glycopyrrolate. Just remember your toxicity for lidocaine. Your max dose is going to be 5 mg per kg, and 4% lidocaine, which we don't have in my ED, but that's 40 mg per 1 cc.